Welcome, everyone, and good afternoon.
Hello.
We'll give a few more people a chance to connect. Good morning to those of you on the West Coast, and good afternoon to the rest of you. My name is Jill Kagan, and I am the director of the Arch National Respite Network and Resource Center. Thank you all so much for joining today's webinar, Time for Living and Caring, an approach to planning respite time to maximize caregiver benefit. We're so very pleased that we are able to provide remote live captioning today. And the live captioning, for those of you who might be interested, is available by enabling the little CC icon for closed captions in your Zoom tray. The webinar is also being recorded and will be made available to everyone on the Arch website in a day or two. We'll also post in a few minutes a link to today's PowerPoint slides in the chat. Next slide, please. Given the interest in this topic, we did extend the invitation very broadly. So we're expecting a pretty big crowd today. And I want to welcome those of you who are new to Arch. Please feel free to introduce yourselves in the chat with your name, your organization, and your state. We'd really love to know who is with us today. For those of you who are not familiar with Arch, we're currently funded by the Administration for Community Living in the Department of Health and Human Services to house the Lifespan Respite Technical Assistance and Resource Center. We provide training and technical assistance to the Lifespan Respite Care Program grantees, to their partners, including state respite and caregiving coalitions, and to the respite field and the public more broadly. For those of you who may not be familiar with it, the Lifespan Respite Care Program is a federally funded initiative that helps states build coordinated systems of respite care services that support all family caregivers who are caring for anyone of any age or any condition. And while each state program is a little different, most of them do assist family caregivers in paying for respite services, especially for those who do not qualify for other public funding sources. And they most often do that through self-directed respite voucher, grant, or stipend programs. The Lifespan Respite grantees also help address the direct care workforce crisis, specifically around the shortage of respite providers and programs by recruiting and training new respite providers and volunteers, and by funding innovative volunteer and faith-based respite programs. And lastly, and maybe most importantly, they do work with family caregivers to help connect them to these services and supports. Arch also provides information directly to family caregivers to help them find respite in their communities. We have a robust catalog of fact sheets and tools on our website. We also link them to the State Lifespan Respite Program grantee or the State Respite Coalition. Unfortunately, because of limited funding, not every state has a Lifespan Respite Program or coalition. So we also maintain an online national respite locator service that's available to all family caregivers and those who assist them. Our National Respite Coalition is the policy division of Arch, and we advocate for respite in all programs at the federal level. Again, you can find really an abundance of written resources, recorded webinars, and other helpful information. And you can connect with us at any time through our website, archrespite.org. Next slide, please. I did want to let you know we have Marcia O'Malley is helping us today with our slides and with any technology. So if you have any technological issues, feel free to direct message Marcia, and she can help you with any technical issues you might have. I'm so very pleased today to introduce our speakers. Dr. Rebecca Utz is Associate Dean of Research and Graduate Education and Professor in the Department of Sociology, College of Social and Behavioral Science at the University of Utah. Dr. Utz, we were also so fortunate that she served on the Arch Committee for Advancement of Respite Research, where she helped formulate the value of respite research framework, and also was invaluable in helping us develop the CARS recommendations for the use of common data elements in respite research. She is also currently co-leading the evaluation of the respite program grantees who are being funded through the Center for Dementia Respite Innovation at the Alzheimer's Association. And she's joined today by a member of her research team, Catherine Sparks, who's the clinical research manager, also based at the University of Utah. We at Arch, we first learned about the value to family caregivers of planning for respite time from Dr. Utz's colleague, Dr. Dale Lund. Way back in 2009, he was actually a keynote at one of our very first federally funded Arch conferences in California. And we've been following their research over the last 15 years. And many of our lifespan respite grantees and their partners have incorporated their findings about the benefits of respite time into tools that help them work with and counsel family caregivers to maximize the benefits of their very precious respite time. And so we are really very excited to learn today about the effectiveness of an app, Time for Living and Caring, that Dr. Utz developed to make it even easier for family caregivers to plan how and when they'll use their respite time. So we're just so grateful to them for being with us today. Everyone, please feel free to post your questions in the chat at any time. If we don't get to answer them directly in the chat, the presenters will respond at the end of their presentation to any outstanding questions, and we should have ample time at the end for Q&A. So Becky and Kathy, thank you both so much for taking time out of your busy schedule to present today, and I'm going to turn it over to you.
Jill, and thanks for the invitation to present to this group today. And you can go to the next slide. So what I want to do today is give you, Jill mentioned, this is kind of a 15-year set of research. And I want to show you some of the data that we have used to sort of learn more about caregivers and their use of respite time, how and why respite is important, and what aspects of respite may or may not be important to caregivers in terms of their overall well-being, how that led to the creation of an intervention, and then ultimately how do we evaluate that, and sort of where are we today with all of that. So it will be sort of a 15-year drive-by of this research area, leading to some of the tools that we'll talk about. So next slide, please. As Jill mentioned, my name is Rebecca Utz. I am a researcher at the University of Utah. And my research team members, I do not do this alone. They're all listed here on the left-hand side. We will also hear from Kathy Sparks, who has sort of led our research team over the last several years. On the right-hand side of this picture, I want to point out that much of this work that I'm going to talk about has been done in partnership with community partners. So these may be respite providers. These are leaders, community leaders that are really invested in supporting caregivers and different diverse communities that are dealing with caregiving of dementia, of disability, or any other sort of caregiving that people are doing. Most of the work that I'm talking about today has been funded by the National Institutes on Aging, and that is the grant noted below. Next slide, please. So I think I'm probably preaching to the choir here and don't need to say that much, but it's estimated that about 1 in 4 American adults are providing care. to somebody in our homes and communities. Caregivers are mostly unpaid. They are overwhelmed. They feel financial stress associated with their caregiving. They oftentimes change or have to make sacrifices to their work. And they are performing everyday activities such as bathing, cleaning, transportation, financial support, as well as sometimes very complex medical care.
Hi.
If
Hi, Miss Dorothy.
if caregivers, if we had to pay the caregivers for all the work that they were doing, it is estimated that this is a value of about $600 billion per year. Caregivers are a backbone, a foundation of our long-term supports and services system in the United States. The one thing to note that caregivers, the majority of them on this graphic here on the left, it says that 84% of caregivers report that they need more information, they need help, they need support. Next slide. And the one thing that they ask for most often is respite. Caregivers are looking for a break. Next slide, please. And when we define respite, most of us, again, I think a lot of you, as I was looking at the chat, a lot of you are working in the respite industry. Respite is any sort of planned or emergency care provided to a child or adult with a special need in order to provide that temporary relief to the family caregiver. This could be provided through in-home services, through adult day centers or any other sort of day centers, as well as residential or overnight respite. In addition, I think what COVID taught us is that respite is not always just the formal service that is provided to caregivers, but respite is also provided by all those sort of tag teaming, informal, well, they're probably formalized relationships that caregivers have with friends, families, and neighbors to give them a regular break from caregiving opportunities. Next slide, please. Now, from the research perspective, one of the things that we began to see is that the research on respite, it wasn't all that promising. And even though caregivers constantly said, I just need a break, that's the most needed service, about half of them reported being not satisfied with any respite time that they had. And this is a really troubling finding from a research perspective because it's really hard when we have limited resources to pay for these kinds of supportive services and policy. We don't want the research to say, oh, caregivers aren't getting that much benefit from respite and almost half of them are not satisfied, because that's just going to mean like, oh, let's just cut the budget for our respite programs. But this is also the kind of programming that caregivers want. So we, from a research community, said we got to figure out, why are caregivers not satisfied with their respite time? How can we maximize the benefit and the satisfaction that caregivers get from this service that they say is so needed and so wanted? Next slide, please. So this leads us to our general research questions and sort of a research agenda that has unfolded over the last 15 years and will extend into the future. Next slide, please. As we started to explore with caregivers, so many caregivers were just saying, well, I'm not really a caregiver. I'm just doing what families do. And it was this line of thinking that many caregivers said, I don't really deserve a break because I don't think I'm doing anything all that hard. So respite or a break is not something I'm really eligible for. So that was sort of the first thing, of just getting people to recognize that they are a caregiver and that they do deserve and need a break. Next slide. Some of the other things that we began to hear from caregivers is that just taking respite, having somebody come into the home or using some sort of service comes with a lot of anxieties and worries. So for example, here's a quote that one caregiver started saying, and this was a very common thing: the house is a wreck. I haven't had time to clean. I don't want anybody coming over until I clean. So they felt like they couldn't even bring somebody in the home to give them a break, but they weren't able to do the stuff to get their house in order, that they felt comfortable taking that break and having somebody else come in and support them. Next slide is another.
How do I get the audio one on this thing?
Is another example of some of the worries that caregivers have. For example, the man on the left says, why do I get a break? She has to stay home. She'll be mad at me for leaving her at home. And so there was this guilt of saying the caregiver doesn't get the break because the person that they're caring for is still stuck at home. And the other slide here on the right, another common experience of caregivers is saying, well, I'm just embarrassed that he's not going to treat the staff very well. He can be pretty mean. And so they said, I can handle the behaviors of the person that they're caring for, but I don't want to bring somebody else in because it's embarrassing. So all of these stressors, these worries are barriers to caregivers using respite. Next slide. The other thing that we began to notice is that we started looking at like, well, what are caregivers doing during their respite time? And is it how they're spending their time? And that's what's sort of driving this, that they're not very satisfied with their respite services. Several caregivers said things like, oh, when I had respite, I just wasted my time watching television. I wish I could have relaxed, but I had to help others and make visits. I would like to stay home alone and just work on projects I've never had time for. So these kind of thoughts, where we first went with this, and if you go to the next slide, it helps us think about respite time use. So how are people using their time? And here we thought, okay, if people use their respite time to do these more diversionary, leisure kinds of activities, maybe then they get better outcomes. Or if they're doing something where they don't feel like, oh, I just had to clean, I had to run more errands, I had to, I just wasted my time watching TV. If they're able to do the leisure activities, maybe they get more benefit. So what we started to look at here is how do people, so what was their desired time use versus their actual time use in respite that they had scheduled. Now, the takeaway point here is it does not matter what kinds of activities that people do. And I think there's a few more animations here, so you can click them and I will talk about them one at a time. So with housework or sleeping or napping or time with friends, these are a few that I just want to draw your attention to. You can see that there's a bit of a disparity between how people desire to spend their time versus how they actually spent their time when they had respite available to them. Housework, they desired to only spend 2.5 hours, 2.4 hours doing housework, but they actually spent 3.3. There's a bit of a discrepancy there in the amount of time that they wanted to spend versus what they actually did spend. Napping, they didn't get as much napping time as they wanted. Time with friends, they also didn't get as much. Now, the important thing that we started to find here from this research is that it is the discrepancy between what they had desired or planned to do versus their actual time use that had the biggest difference on caregivers' well-being, on their burden levels, on their anxiety levels, ultimately on their satisfaction with respite. So this is where we then said, okay, the key here is all about respite time use. So can we get caregivers to do the kinds of activities that they wanted to do? And a caregiver was perfectly happy if they stayed home and cleaned their house. If cleaning that closet was the thing that was most important to them and they were able to do that during their respite, that was just as important as going to lunch with a friend. So it wasn't the diversionary leisure activities that were most powerful. It was a matter of, did the caregivers do what they wanted to do? Whether it was napping, watching TV, being silent, or some sort of leisure activity. Next slide, please. So this then helped us switch our thinking a little bit. Instead of just saying, oh, by providing respite as a service to caregivers, that's not going to automatically improve caregiver well-being by reducing their burden or anxiety, whatever it may be. Click again, please. What that does for that is that we really began to see that, okay, we have to think about how do we improve a caregiver's satisfaction with respite time use? And how can we help caregivers better plan and get more out of whatever amount of respite time that they have available to themselves? So that's where, if you can click again, please, we said we have an idea for an intervention. Caregivers know and say that they need help, support. In our world, as researchers said, okay, we need to build and create some sort of intervention based off of the data, based on what we know. And our goal here for this intervention was to help caregivers maximize the benefit of their respite by focusing on how they're spending their time. We are going to try to help them plan what they want to do when they have a scheduled respite period. Next slide, please. This is where we then started to create what is called Time for Living and Caring. The first iteration for Time for Living and Caring, remember, I'm giving you a 15-year sort of overview, drive-by of what we're learning about caregiver time use. The first time that we started to create TLC as an intervention, we trained they were students that were probably trained to be social workers or clinical psychologists, counselors, to be coaches for caregivers. And we sent them out, this was way before COVID, we sent them out into people's homes. They did essentially coaching with caregivers, reminding caregivers how important respite was, help them plan what they were going to do for respite. And so we sent people into the homes. And if you click on the next slide, here are some of the testimonials of the first time that we tried TLC with caregivers. They're fantastic results. So caregivers said, I made a greater effort to find fun things to do and actually got around to doing them. This led to other fun things, which I did and will do in the future. It invigorated me. I feel alive, and I'm not just living anymore. I love feeling of success when I achieved my goals. And the goals there were the goals of how they planned and set their respite time use goals. Another caregiver said, I never had time for myself, but since now I set my goals, I feel obligated. It's like a promise I can't cut out. I was unconsciously sliding into a resigned death of my own until I started this study. This program really woke me up to the fact that I needn't give up, rather that by setting goals, I can move forward and feel success, even though my circumstances have not changed. I feel like a new, happier person. So these comments have showed us that, all right, here's the key to getting caregivers to feel better about their respite time use. We need to sort of coach them to plan, to evaluate their respite, to review how they're spending their respite time, and ultimately to help them get to do the kinds of activities that they want to do during their respite time. Next slide, please. What we learned. This intervention, despite the overwhelmingly positive results that I just told you, was absolutely not possible. It was not feasible. We were sending people into homes, and there are no organizations, many of you are on this call, that could afford the time or the resources to do this kind of intervention and support to family caregivers. So next slide. This led us to the next crisis of saying, all right, we've now identified a key to helping caregivers get more benefit out of their respite, but we got to figure out a different way to deliver it that is not so time and person, human resource intensive to deliver. So that's where comes in iteration number 2 of the TLC concept. And this time, this is where we did get funding from the National Institutes on Aging to develop what is called a self-administered technology-delivered intervention to maximize the benefit of respite. Next slide. What this means is we created an app. So how can we, I show it based on a phone, but really with the population that we're serving, it is created for a computer. How can we create a technology-delivered interactive website that helps provide this kind of coaching to caregivers so that they can better plan and maximize the benefit of their respite time use? Next slide, please. So what I want to do at this point is describe a little bit about what TLC looks like as the interactive website. There are 3 primary components to it. One is just information and education. What is respite and why do caregivers need it? The third part on the right-hand side, these are resources and referrals. Just how do I get more respite? So coaching caregivers through how do they find respite? How do they get even more respite if they don't have any? How do they get a regular schedule? And then it's this middle part here, the virtual coaching, is how do they actually use respite? So can we provide a bit of an orientation to our caregivers about how to best use respite and what does respite do for them? We do this through goal setting and goal review. It's a pretty simple process of just planning, setting goals, reviewing goals, increasing self-awareness through that process, and then ultimately just calendaring respite to ensure that there is a consistent respite schedule. Next slide, please. So with the TLC intervention, we then, as this was developed through the National Institute on Aging, this is a research grant. So we also received money for some of the development, which we did, as I mentioned, with the Community Advisory Board. Lots of input from caregivers themselves, as well as organizations that serve caregivers and communities that might benefit from these services. We developed it with the community advisory boards, and then we also spent time doing the assessment and feasibility of this website, this technology delivered intervention. Can we get the same sort of results? So next slide, please. And what I want to do today is to describe for you some of the ways that we evaluated the TLC app. I'll tell you a little bit about sort of the research that we have done. And to start though, well, let me make one point here, and I'll tell you a little bit more about the research in a moment. We did this study and we created the original version of the TLC website specifically with dementia caregivers, but this is a model that can be used with any caregivers. But the data that I will present to you today are from a sample of dementia caregivers that participated in this study. And that was just the funding that we had from the NIA, where the focus was on dementia caregiving. Okay, so next slide. I would like to take a few moments to show you a video that gives you some examples of TLC, as well as some of the initial results that we found. So you can start the video now.
Caregivers do valuable work, but without regular breaks, caregiving can take its toll. Caregivers need and deserve respite and intentional time away from caregiving. But caregivers don't always know how to take respite. They may not feel comfortable taking time for themselves, or they are uncomfortable leaving their loved one with somebody else. The Time for Living and Caring, or TLC program, is a tool designed to help caregivers take the respite they need. TLC is an interactive, fully online, self-administered 16-week program. Caregivers are taught strategies to assess and identify ways to spend upcoming periods of respite time. The goal of TLC is to support caregivers in planning and maximizing the benefit of their respite time. TLC was developed by a team of researchers at the University of Utah with funding from the National Institute on Aging. When the tool was first developed, the research team received significant feedback and consultation from stakeholders, including current and former caregivers, community leaders, and respite providers. From 2020 through 2022, the research team successfully piloted and evaluated the TLC program in a trial with 150 dementia caregivers. When caregivers first log into the TLC tool, they'll take an initial assessment to find out how much respite they're getting currently and how much they would like to get. They're also asked what kinds of activities they like to do. This primes them to start thinking about their own wants and needs. They are then taken to the calendar to schedule respite for the week and indicate what kinds of activities they want to do during that time. At the end of the week, TLC prompts them to review what they did and how they felt during their scheduled respite time. They can then adjust their respite goals for the following week. This weekly review allows each caregiver to plan and maximize the benefit of their respite time, whether they have had very limited or abundant respite time available to them. A dashboard helps caregivers visualize their progress over time. One graph shows how much respite time they had each week compared to the respite goals they set for themselves. A second graph shows the trends in their respite quality from week to week. Finally, TLC has a library of support and educational resources. These include links to local and national respite providers, tips to having conversations with family members about sharing care responsibilities, as well as short mindfulness activities to help caregivers shift their focus to maximize the benefit of their respite time. Because TLC was developed and tested during the time of COVID, there are additional resources showing caregivers how to get respite when formal services may not be available or when caregivers are not able to get extended periods of traditional respite.
The caregivers who used TLC were actively engaged throughout the 16-week study period and reported overwhelmingly positive feedback.
TLC helped caregivers schedule time for themselves. Prior to starting TLC, only 10% of caregivers said they were getting enough respite. By the end of the program, almost half of the caregivers felt they were getting enough respite time. In addition, caregivers significantly improved the quality of their respite time. The percentage of users who reported they were happy with what they chose to do during respite increased from 45% to 74%. Using the TLC tools, participants were able to increase their respite time, maximize the benefit from their respite time, and overall be a better caregiver for themselves and the person being cared for. One participant said, "Budgeting time to myself is paramount to being a good caregiver. Seeing the planned times on the calendar gives me value as a person of worth." Another said, "I like that I schedule my respite. I like that the time I do have to myself or the time I scheduled is labeled respite. It makes me appreciate that I really do have carved out time to stop the world and focus on other things I love to do." And one caregiver said, "Honestly, I am taken aback about how just calendaring time out has made such a difference. Thank you." From this pilot study, 9 out of 10 caregivers said they would recommend the TLC website to other caregivers. These results were achieved with a relatively small amount of time each week. The typical participant accessed the TLC tool just 1 to 2 times each week and spent an average of only 8 minutes per session.
The results of our pilot study provide evidence that the TLC tool helps caregivers, so they can benefit from better planning of their respite time.
Caregivers need and deserve a break.
Hopefully that gives you a bit of an overview of what the website looks like, what we are trying to do with the virtual coaching. And I want to take some time now to describe some of the research and the data that we have that really helped us understand how is this kind of intervention supporting caregivers and what kind of outcomes are we seeing from it. So next slide, please. As I mentioned, the TLC study, the research study piece, so I'm going to go into the research now for a moment. The research study used a sample of dementia caregivers. They used the app or the website for 16 weeks. It was a very controlled trial. It's called a randomized controlled trial. I'll show you that a little bit, where some people received the interventions or different pieces of the intervention at one time and others didn't. And this helped us identify what components of the intervention were most useful to caregivers. So all the caregivers that enrolled in this study, they used the intervention, the website, the TLC tools for 16 weeks. They completed pretty comprehensive monthly surveys. So before they started the intervention at week 4, 8, 16, and then also a month after they stopped using the TLC tools. These surveys asked them about their overall health, their well-being. So this is depression, anxiety. This is also caregiver burden, positive aspects and meaning of caregiving. So both sort of positive and negative experiences, all self-reported on surveys. The participants did receive some cash compensation for being part of the study, and if and as needed, they were provided with a technology such as a Chromebook or laptop in order to participate in the study, as well as Wi-Fi. I'll talk about sort of the technology and Wi-Fi things here in a moment with one of the research studies I want to share with you. Next slide, please. So I want to describe in today's talk 2 different research publications that we have done based off of this sample and the data. And I want to show you the actual data and some of the decision makings that it has led to since doing the pilot study. Next slide, please. The first study that I want to talk about is just sort of overall, what kind of outcomes did we see in caregivers that use the TLC online intervention? Thank you, Jill, for running the chat here. I'm putting live links to some of these research articles. Thank you. Next slide, please. So here we are focusing on anxiety as an outcome. This is an easily measurable outcome of just sort of how anxious do caregivers report. We did these same sort of analyses with burden, but today I'm just going to show you the outcomes of anxiety. So we're going to go a little bit on, you can start clicking on a few little animations and I'll describe them. I'm going to describe the study design. The first thing that I want to show you is that In this study, we do what's called a pre and post design. So before somebody does the intervention and after, we want to get their measurements and is there a change? But we don't just look at sort of those pre-post assessments. We're going to look at, during that time, one group. So we're going to randomize people into receiving the full intervention all the way through, and then we're going to look at sort of what were their outcomes over time. Group 2, they're not going to get part of the intervention. So we're going to study them. We're going to get the pre-assessment, but we're going to give them pieces of the intervention over time so we can start to assess which pieces and parts of the intervention itself are most useful to the caregivers themselves. Next slide. And this is where we have a couple of different groups. And there are 2 primary components to the TLC intervention, and these are in those boxes up top. And next slide, please. I'll click on a few things to draw our attention. We have 2 groups. The group that receives TLC, we called them the immediate group. They get everything that is described on this website all at once from the start. The delayed group gets some of it, and then the rest of it gets added in around 8 weeks in the middle of their study period. Okay, next slide or next click. The 2 main components that we're starting to see on this is across the 20-week period, and then click again, who is receiving which elements of this? We have 2 primary elements that we think are the most important to this intervention of coaching people. One is an interactive calendar where they can schedule their respite from week to week. And the second piece is the coaching. And the coaching is where we really guide caregivers through goal setting, goal review, asking them what kinds of activities they want to do. So the first one is getting a respite block of time consistently on a calendar. And the second one is making sure that we talk about that time use. Are they doing the kinds of activities that they wanted to do? So next click there. When we look at the calendar component, we call that one D1. Next click, the coaching component we call D2. And next click, you'll see here in the 2 different groups, we are going to provide them different aspects of that coaching versus the calendar at different components. What does the coaching consist of? We talked about this a little bit before. This is just on a weekly basis. We ask caregivers to schedule. This uses the calendar, but then we also ask them and provide them the coaching piece where they're going to plan the kinds of activities, the time use that they want. And then at the end of the week, we ask them to review. Next click, please. That review, we ask them about their time use. And this goes back to that original set of data that I showed just several slides ago, trying to get at this idea of what did they want to do, their desired time use versus their actual time use. And here we ask several review questions at the end of every week. So first was, did you have respite this week? So were you able to take respite with the time that you had scheduled? And did you do the activities that you had scheduled? So this is a very sort of experience. What was your experience of respite this week? But then we have them evaluate their experience of respite by asking them a few more questions at the end of the week. We ask them sort of, do you feel that you had enough respite time this week? Are you happy with how you spent your respite time this week? And then finally, are you a better caregiver because of the respite that you had this week? So these more evaluative questions allow caregivers to really just reflect upon what kind of respite did they have? Did they have enough? And how did it make them feel for having that respite? After they answer those questions about their time use, their review, then they're sort of guided back through that virtual coaching of, okay, now schedule your respite out for the coming weeks. Plan out what you have. What are the barriers that you're going to face? Why were you not as successful this week? So that's what we have. This is just in a nutshell how the family, how the virtual coaching happens. And next slide. All of the responses are plotted out on these dashboards that were also demonstrated in the video. That is showing on the left side, the dashboard is just showing the average respite quality. Those are all those evaluation questions that we sort of create a score for each person. And we show them sort of how are they feeling about their respite each week. Hopefully by seeing it on a dashboard plotted over time, they can start to gain that self-awareness of when are they feeling better versus When was their respite really serving the needs and the interests that they had? And then on the right-hand side of the dashboard, this is just showing them how many hours of respite time do they have. They can always set a goal line of, I hope to have 2 hours of respite per week or 40 hours of respite per week. And are they trending towards that goal of just getting a consistent, regularly scheduled respite time? So next slide, please. Looking at all that, so we're going to click through here. These are some of the results, and I'm only going to skim over these quickly. But those two groups that we said that some of them are going to get the calendar only for a while, where they learn to schedule respite. Some of them are going to get the calendar and coaching together. Some of them then only get the coaching a little bit later. So if we look at these data, these are plotting the two different groups that receive the TLC intervention. This is their average predicted level of anxiety symptoms as self-reported. And then across the bottom, or from left to right, we're going to see from week 0 to week 20. So if you click on the next animation here, I'll draw our attention to the first 8-week period. The group that received everything, you see that they had no change in their anxiety. The group that only got the calendaring, so they learned to sort of get more regular blocks of respite, but they weren't getting the coaching and that review component, their anxiety increased over that first 8-week period. Click on the next animation here. When we now look at week 16 at these two groups, the group that did not get the coaching at first, they then started receiving the coaching at week 8, and you'll see that line for them, the dashed line, comes down. Their anxiety levels then decreased. And they are sort of the level of the people that received the coaching and the calendar all at once, they maintained their levels of anxiety. And sometimes when we work with caregivers and outcomes across time for caregivers, our goal is to keep people in a maintenance state. We're not necessarily always reducing levels of anxiety, but we don't want them to keep escalating into higher states of anxiety or burden. So typically in caregivers, when we look at outcomes results like this, it's the maintenance of a symptom is our goal, or at least that's considered, or at least helping caregivers not escalate into a higher stress level over time. Now, one more click here. What we see here at the last period from week 16 on, week 16 is when the intervention, they no longer have access to the intervention. You'll see with both groups that their anxiety levels begin to increase over time when they no longer had access to these tools that help them sort of set their goals and plan their respite. Next slide, please. This results right here are data that we can actually put to say, okay, it is the coaching piece. It is that weekly review and that planning, the goal review, goal setting techniques that caregivers were walked through that were the most effective piece of getting sort of the outcomes that we were looking for in caregivers. So that's some of the data, some of the research design that we used to emphasize this is sort of the evidence base that we use to say these are the most important kinds of tools that we can be providing to caregivers, and it is that which is focused on the virtual coaching. Next slide, please. I want to take another opportunity to share with you a second set of research data. There's a bunch of research data that we have across the sample overall. But one of the criticisms that we get for TLC is saying, you know what, I don't think our caregivers want to access support online. They're not going to use computers to access this support, and I get it. I get it. Computer-based delivery, interventions, apps that are delivered in this way are not for all of our caregivers. But I want to show you some data that puts some evidence to this point as well. So next slide, please. In those surveys that we did with the caregivers in this sample, we did what was called the computer proficiency questionnaire. So every caregiver that participated in this trial, we had them answer a series of 12 questions about their overall computer proficiency. So we asked them, have you ever tried, or you've never tried to, you're very confident, you can very easily do different tasks related to any sort of basic computing, printing, communication, accessing the internet, calendaring software, and other multimedia resources. We use this sort of computer proficiency questionnaire to say how proficient, how comfortable, how competent do caregivers feel in accessing these kinds of resources. So next slide. I'm going to show you some data. I'll walk you through this data. Absolutely, we know that age is associated with computer proficiency. So on the left-hand side, you see that that line sort of tips down there. All that is showing you is that from age 20 to the age 100, we see that the average computer proficiency score decreases. But what we also want to point out is that even our older adults, many of them have fairly high computer proficiency scores on the overall range of those 12 items that I talked to you about. On the right-hand side, this is just another way of describing sort of the age distribution of computer proficiency. The blue box there would be the youngest persons in our sample. This is those that are under the age of 65. And then over on the right side, the green box are those that are 75 or older. Now, you see that the boxes are at different levels. It's basically saying that our youngest age group, they have the highest computer proficiency. Our oldest age group has the lowest computer proficiency. But what you notice is the sort of width of those bars. The older age groups have a much greater diversity and disparity in how computer proficient they are. So absolutely, I agree. Computer proficiency is going to change by age. But what we wanted to look at is, does the experience of using an app like this differ by one's level of computer proficiency? Next slide, please. And with that, the data that we have, and I'm not going to show you any more sort of plots or data, but what we found is that neither age nor one's individual score on the computer proficiency score was associated with how many times they logged in to the TLC app. Neither of these characteristics were associated with how much time they spent on the app. And then most importantly, neither age nor one's level of computer proficiency was associated with how they assessed the intervention benefit or how much benefit they were receiving on some of the outcomes that we looked at. So this is here to say that computer proficiency is an important characteristic that differs by age, but older adults and those that have lower computer proficiency are still using these kinds of resources in about the same way that those that are younger and those that have higher computer proficiency. The only other caveat that I note here on the bottom is that our very low computer proficiency, people that were very, very low on this, they were associated with some attrition. So this is a sample that probably these are the parts of our population that just really don't want to, or it's a lot of trouble and a burden for them to access these kind of supportive resources online. Next slide, please. What these results are telling us is that older adults or those with lower computer proficiency, they're accessing the computer. And one of the things that we found from our results is that by having TLC available online, we saw that some caregivers were accessing this in the middle of the night, in times where we would not have traditional, say, in-person focus groups or during office hours. That's not necessarily when they were always accessing these resources. So the online availability of resources like this provide a lot of flexibility and allow people, caregivers especially, that are a time-burdened population, to access the resources when they need them and when they have the time available. So while not everybody wants to use a computer to get resources, online technologies are a really flexible way to reach populations that are geographically burdened or geographically isolated and those that are not able to access things during office hours. Next slide, please. I do want to point out, while we were doing the trial and while we had funding from the NIA to develop these tools and evaluate them, we did have for TLC somebody that was available by phone, by email, by text to support the people using it. We don't necessarily have that now, but this was an important resource for some people to help navigate the technology. Next slide, please. So overall, we just sort of have shared with you some of the research that led to the development of TLC, how we developed it in the way that we did, some of the data that we have assembled to say, is this effective? This is an example of evidence-based creation of programming, supportive programming, and for populations that are looking for this information. And if we go to the next slide, there's a few sort of takeaway messages that I have for those of you that may be respite providers, or those of you who may be working with caregivers looking at respite. And the biggest takeaway point that I think we came up with through this study is that as we onboard people into using respite, so much of that intake process is about the care recipient, the person that is going to be cared for during respite time. But there's also a need to start to give an orientation to the caregivers themselves, to remind them why respite is so important to them, how they can use respite, how and why maybe they have some worries or anxieties about hesitations, barriers to using respite, just to normalize those feelings and to make sure that caregivers, one, identify that they need and also that they deserve a break. So that is a mantra that we have had throughout this research, is that caregivers need and deserve a break. And caregivers really benefit from hearing that they need and deserve a break. And that it's okay for them to take a break. So that's one piece that we need to think about. How do we provide that orientation, maybe upon intake of new clients into a respite services? There's that moment to take the caregivers aside and say, respite is for you. And just to normalize that, make them feel they need and deserve a break. Secondly, I think that what we learned here is that respite planning, that virtual coaching, where we have people try to get a regular schedule of respite on a calendar, but more importantly, have them reflect upon, what do you want to do? Did you do that? And how did it make you feel by doing that kind of activity? That respite planning helps caregivers maximize and gain benefit from whatever amount of respite time that they have available. So we don't want to encourage all of our respite clients to go out and do all the leisure activities, but we want to encourage them to plan and do the activities that are most meaningful to them, and to also make sure that they're getting a regularly scheduled respite periods onto their calendar. So those are sort of the takeaway messages that I think that this research, in terms of application for those of us providing respite in the community, is to think about, how do we orient our caregivers to using those services so that they benefit. And yes, of course, as respite providers, we also want to make sure, how do we train the respite providers to keep the other individuals safe and secure while they are providing respite, but also encouraging caregivers that respite is for them as well, maybe primarily for them, and their outcomes are really important. So at this time, I would like to flip this over to Kathy Sparks, who's going to tell you how we have taken the most essential elements of this TLC website and put them into a version that you all can access. So Kathy, go ahead, and next slide, please.
All right, thank you. So yes, we have taken the most essential elements of the intervention, and we have made them available for free on a website. There will be a flyer with this QR code and URL posted in the chat for you. You're welcome to print it and share it either in person or via email with caregivers you know. Be aware that this is designed as a website and not an app. We do recommend that it is accessed on a computer or larger device. It does not function as well on a phone. And we Also want to remind you that, that this website and tools, while we developed it with dementia caregivers, it is applicable to all family caregivers, not just those caring for someone with dementia. So it is appropriate for anyone in need of respite support. Next slide. So we do have additional resources available on the site that are accessible without logging in. And yeah, on the resource page, which I'll go over in just a minute, users will need to log in to access the calendar tool. And this is to enable the personalized tracking and the dashboard feedback that we've created. Next slide. Oh, one more, maybe two more. Yeah, one more. Great. So 3 of the most frequently used resources from the study are included on the resource page. And again, these are available without logging in. The first one is caregivers can download a printable information sheet. This is a simple tool that caregivers can use to organize information, to leave with someone coming into the home to provide respite. The second one, we developed a caregiver-specific 8-minute meditation. And this is one of my favorite tools. This can be used as a brief form of respite in and of itself, or as a meditation to do prior to scheduled respite time to kind of help reset mental and emotional focus to get the most, again, out of that time that they've got scheduled. And then last, journaling did prove to be very beneficial. And so we've included some potential writing prompts here, things like celebrate the wins, turning goals into to-do lists, acknowledging those they have helped and those that have helped them. Next slide, please. Also on the resource page, we've provided some links to resources that most of you are probably aware of, like the Family Caregiver Alliance and the Arch Respite Locator. Sometimes respite is not provided by formal services, so we have included links for caregivers to help them draw a care map, identifying potential sources of informal support and tips. We offer some tips from AARP on how to facilitate a family meeting to discuss care and respite support. Next slide, please. Again, to access the calendar and dashboard tools, you do need to use a Google account. If someone does not have a Google account, this process will take them through the steps to create one. And again, just as a reminder about using this on a computer versus a phone, the calendar tool in particular is not designed to be used on a phone, so a larger device is better. Next slide, please. So yeah, we do hope that you'll share these tools and resources provided on the website with any caregivers that you know that might need some respite support. We also want to remind you, I think Becky just went over this, but we'll say it again, that many caregivers may need some orientation and simple encouragement to understand that they need and deserve a break, and that they can maximize the benefit if they plan their respite time. All right, any final comments, Becky? Thank you for letting us share this with you today.
No, so thank you. I guess we will answer any questions that are in the chat. One thing that I wanted to bring up is at this point, the tools that are available on this website, they are just sort of the stripped down version of what we created. They should be accessible and as a website. There is a login where individuals can track their data over time if they continue to log in. Those data are not stored or captured by anybody on the research team anymore. They're only stored and captured on an individual's Gmail account so that they can see their dashboard over time. So I just wanted to say there is no more research or data being collected from these tools. These resources and model are just being provided to those that may benefit from it.
Well, thank you so much, Becky and Catherine. Really fascinating and such a great presentation. It made it accessible to all of us on the call. We've had lots of comments in the chat as you were speaking. A lot of family caregivers sharing their personal experiences around using respite. And I think, Becky, you responded and said, yes, these are very common experiences of many caregivers, and you're not alone in feeling that way. I don't know if you have anything you wanted to add to that, just to make family caregivers feel more comfortable about even considering using respite.
Right. I mean, this was one of the biggest challenges that we see, that caregivers, and somebody in the chat did say, yeah, I get that I should be using respite, but it's hard. I don't know how to do it. The person I care for only wants me. They make me feel bad. This is such a common experience. One of the things that we have found through this study is that caregivers that felt exactly that same way, after they used sort of 16 weeks of it, one of the things that we notice is that they increased the amount of respite time that they had over time. So maybe they initially only had 1 or 2 hours a week every 2 weeks. But by going through this process and really prioritizing respite, they started to see an increase in the amount of respite time that they had overall. So part of it is practice for the caregiver to take respite, to schedule it, to prioritize it. But then it's also practice for the care recipient and the person that is providing respite, that you all become comfortable with it. So the more we've found that the more that people keep a consistently scheduled respite calendar, the more practice that all parties have and the more comfort that all parties have with taking respite. And ultimately, those breaks do provide benefits to both the care recipient and the caregiver.
One thing that we've heard from some caregivers also is, if you plan to stay with the care recipient the first couple of times that you're using respite, this is before you're planning your own respite time, just to build up that confidence and about using respite and that it's safe and secure, to spend that time with the care recipient, and realize that it's a safe and good experience for everyone.
Yeah. Another question that we had on here is, how did we approach the participatory design? Oh my gosh, the chat just moved really fast and I lost the question. But it was basically asking us about the design process of TLC. And as we mentioned, we had a really thoughtful sort of co-created design process. I myself am a researcher that has never imagined that I would be creating some sort of app. So this co-design process included those of that had the research and the ideas of what we wanted to create through this virtual coaching. We then also had a technical team, which included everywhere from composers that did the music on videos, to the software designers, to the graphic designers, and everybody in between on our technical team. And then we also had one of those very first pictures that I showed you, caregivers, respite providers, as well as community leaders. And every time we developed a sort of prototype of the website or language to be used on the website, the logo, the coloring, we would come together as an advisory board, technical, research, as well as community, and we would discuss something really specific. The videos that we created, we showed you one of the videos here. That script was completely created by our advisory boards. They developed the language. Many of the tools in the apps themselves, which use these slider bars with happy and sad faces, those were developed by the advisory board. Just as saying, here's what we believe is most accessible. Also, we did a lot of prototyping, like beta testing. It's called beta testing, where the technical team just went through different iterations and tried to make things as user-friendly as possible. And again, the version that we are making available on a website now does not have all of those features, because we had to create a stripped-down version that can live on a website, more than a really structured, standardized, controlled research intervention that we had originally.
Speaking of that video, we had several people ask if there was a direct link to the video itself?
Yes. So the video is on the website. Do we have I know we posted the QR code, but the website itself describes the study, the research, as well as the tools that we just presented today. And the video is broken into different components. One is just describing what is the value of respite and why should we plan. It's a great resource to give to any of your clients. It's pretty generic. And then the other one describes kind of the results of TLC and specifically about the TLC tools that we created.
Great, thank you. Going back a bit in your presentation, you may have missed this question when you were talking about computer proficiency. Someone wanted to know if those findings differed based on social economic status, ethnicity, other demographics.
That's a great question. And in that actual research article, we controlled for all these other characteristics around education, socioeconomic status. And surprisingly, I mean, we found that computer proficiency as a measurement differs by age. It differs by education in the ways that we would expect. But what we were really heartened to learn is that people's experience using this app and the benefit they got from it did not really differ based off of any of these other characteristics.
In a similar vein, people wanted to know if the tools were available in languages other than English, and resources available with universal design or technology for all who need adaptations. For example, different people with different disabilities.
Right now, no. Right now, everything and the research study that we had was all conducted in English. And the website and the original tools that we created did have a lot of universal design principles on them. But right now, sort of these public tools that we have just thrown up on a website probably do not have full accessibility features unless they're built into the website or the browser that an individual uses overall.
Okay, I'm seeing if there are any other questions in the chat here. Please also feel free if you'd like to raise your hand and unmute yourselves to ask a question live. We'd welcome that as well.
There's a question in the chat that just said, is this program to help caregivers find respite, or is this a program to help us get respite for caregivers? It's kind of neither of those. What these tools or just this thinking is really about caregivers that are using respite. How can we help them use respite with less worry and also to get the benefit from the respite time that they're receiving? The resources on here are helping to point caregivers into how can they locate other forms of respite so that they can start getting a regular schedule. So it's really about getting a regular calendar of respite for caregivers, as well as coaching for those caregivers that are using respite to make sure that they're getting the biggest benefit and they're getting the most satisfaction from the services that they're receiving.
Also, Arch has lots of resources on how to help caregivers find and use respite, so please feel free to visit our website. There's a great question on here. Someone was asking if you saw if there were specific types of respite that caregivers took that were successful at helping them want to take more respite time for themselves. Were there particular models, I guess is what they're asking? Or
particular activities that were most useful, the answer is no. It's whatever activity that somebody wanted to do. For some people, the most beneficial activities were cleaning a closet or napping. For some people, it was taking a vacation and meeting up with friends. But that was so variable and so personal to every individual. And so the most important kind of respite activities are the activities that the caregiver say they want to do. And that could be, I just want these 3 hours to clean out my car that I haven't been able to wash my car for the past 3 years. And if they're able to do that, that brought them a lot of satisfaction. And the other thing that we do begin to see from this research and others is that if we can get caregivers a regular schedule of respite, The amount of hours differs for everybody based off of their circumstances. For an employed caregiver, they may need 40 hours of respite. For other caregivers, they may need 4 hours of respite per week. But the goal here is that caregivers have something every week on a regular schedule. And that seems to be the most effective model of respite, the regular scheduled.
So it doesn't necessarily matter if it's in-home or out of home or professionally provided or volunteer provided. Did you collect any kind of information related also to the type of care? It really was more about
No.
the time use.
It really was just about how much time people had. And the other thing is that we developed these tools and did most of this study. I think we launched it almost as COVID was launching into our world, where so many of our formal respite providers shut down. And so what we did see through the course of this study and just sort of working with caregivers over the last 5 years is that sometimes respite also could come in activities where caregivers never even were able to leave their home. And it was sort of like that meditation script that we developed. That was sort of a 10-minute reset for many caregivers. And so we did collect a lot of data where caregivers said, I couldn't get out. We couldn't. We lost all these sort of services that we had. But we did not really look at what kinds of respite. We didn't evaluate the types of respite services people were getting to see is there one that's more beneficial.
I think that's what Erica wanted to ask. So I think I asked it for her. Thank you, Erica. There's another question here. Were there any caregiver segments, for example, rural, non-English speaking, LGBTQ, who are underrepresented in the design or testing process?
We had a really diverse advisory board in that co-creation process that helped design, that represented all those groups that we just mentioned. In terms of the sample itself, every research sample, we're going to be a bit biased to white higher education. Those are the populations that are most willing to participate in research studies formally. And I don't know if I have our exact demographics, but we do have the demographics of the sample that was used for this study map onto fairly well the national population in terms of major demographics.
Great, let's see if there's any other questions here. What caregiver outcomes beyond anxiety were measured?
Okay, so
Satisfaction,
we
quality of life,
measured.
anything else?
From a measurement standpoint, yes, today I showed some of the data on anxiety, but we also measured caregiver burden. There was overall physical and mental health where we get at some depressive symptoms. We had measures of desire to institutionalize, and then we also had kind of the positives of some of these more negatively balanced measures, like the positive aspects of caregiving. How much meaning do people get from caregiving, as well as positive well-being, sort of emotional well-being there as well. And if anybody's interested, we have several other papers that look at some of those outcomes where we have analyzed those data as well.
Here's a good question. Are there licensing or cost barriers for public agencies interested in adopting or adapting the TLC app?
So no, there's not. So what we have provided to you today is an open, accessible website with a stripped down version of everything sort of that we learned. And we felt that as a research community, that was our kind of obligation to make these tools and some of these ideas and the research accessible. Now, what that means, we did not approach a commercialization strategy with TLC. Well, we did. We've explored that. But as you know, respite and respite providers are probably not the biggest money makers. And so we did not pursue a commercialization process of TLC. So everything that exists on the websites now exist as they are. There is not a business behind it developing it. If any of you on here like these ideas and want to develop it as a business, come talk to us. And we can think about sort of how to create these tools in an ongoing commercialization framework.
Someone is asking a question about, related to the lack of respite that's currently available for people. Would tying the use of the app to something like a respite voucher program be
Right.
beneficial? And that's exactly why we're sharing it with all of you.
Yes.
Who are running respite voucher programs or other community-based respite options. That's certainly tying that form of financing for respite or a direct service would maximize the benefits that family caregivers are getting from the respite you provide. Absolutely. I think we do want to link those.
Well, and I think that, Jill, you alluded to this before, but we have heard of other caregiver support programs or respite providers in states that have used some of these ideas of just asking caregivers these few questions about what did you do? What do you want to do? Did you do it? How did it make you feel? That they've adopted that into their intake procedures and training with caregivers. And so some of this can be done really low tech. It doesn't have to have an app. Some of these resources are just to make sure that respite providers are able to just keep reminding caregivers that respite's important for them and how they use respite can really make a difference. It helps us, even if we have limited resources of giving caregivers the maximum amount of hours they want in caregiving, but we want to make sure that we maximize what they're doing and the benefit that they're getting from whatever limited hours they are available to have.
Absolutely. And I think I mentioned earlier that some of our lifespan respite grantees do use a tool currently to help a caregiver plan their respite time and then monitor, how did you use your respite time and do the outcomes differ based on whether they planned for that respite time or not. So they're using very simplistic tools. Nothing as wonderful as your app.
But it's the ideas. And I think
Yes.
sometimes when we have to take research and boil it down to its essence, they really are simple tools and they're reminders that we can do. And low tech is sometimes the best way that we reach these populations. To answer some of these questions in the chat, I see there are some questions about the coaching. The coaches are, we called it a virtual coach. They were just prompts that were given in a weekly review by the website. So if you log on once a week, it's going to ask you questions. So it was a very standardized set of prompts. These were not real life coaches. Kind of a decade ago, we did try a model where we sent out actual humans as the coaches. It worked really well, but that's not feasible. None of us can afford that or the time. And so the coaches here are a computer prompt, asking individuals those questions and hoping that those prompts increase their self-awareness about those topics. Question about HIPAA compliance and caregiver privacy in mind. Absolutely, yes. As we had to do the research study, we were very mindful of keeping data. And all the data that we presented today are completely anonymous and nobody has been identified. The tools that are available on the website that we presented today, an individual can choose to sign in and create their own account, but that is their own personal data. These are not being provided by any sort of healthcare entity, and no health information is being provided. It is just a tool that caregivers can use on their own to track, to plan their calendar as well as their respite time use.
There was one question here about whether or not you collaborated with AAAs or state respite coalitions, and certainly collaborated with Arch.
Yes. And so many organizations have been involved in this project over the past gosh, 15 years of giving insight and advice of how to create these tools, how to understand what caregivers are doing, how to reach caregivers. And so, yes, we as the researchers have wanted to involve all of these people throughout the entire process, including doing webinars like this to share the results with you. The other thing that we didn't talk about today was we also did a couple of times throughout the process surveys, interviews, focus groups with respite providers overall, just to keep running by results, ideas, what are the essential features? And so that's also helped us develop these products throughout time.
I think someone wants a clarification on the coaches.
The coaches, yeah, so the coaches.
Is it AI generated?
No, it's because this was developed 5 years ago. And so AI has really sort of taken off in different ways. The coaching that people get is exactly the same week to week. It is not personalized. It is not, if we were developing it now, yeah, we would use AI chatbots to give a little bit more personalized coaching to each individual. But no, this is just, all right, this week you were supposed to do that. They were standardized questions.
Great, thank you. I think we've gotten to most of the questions in the chat. If not, does anyone want to unmute themselves and ask a question we may have missed? I don't see any. Yes, one came through. Would the intervention be adaptable for other caregiving populations? I think you mentioned that.
Absolutely. And
Yeah.
so, as we mentioned, the actual trial that we did supported by NIA was limited to dementia caregivers, just based off of the funding sources. The version that the sort of scaled back public version on the website that exists now has been stripped of sort of that Alzheimer's dementia focus to be sort of caregivers overall. And we believe that all of the tools, the ideas, the theories, the data associated with TLC are applicable to any kind of caregiver.
Wonderful. If you think of any questions after you disconnect from the webinar, please feel free to forward them to Arch and we'll share them with our presenters. I'm sure they'd be happy to respond to any additional questions. I want to thank you both so much. Thank you, Kathy. Thank you, Becky. I look forward to our continued collaboration on this and sharing this wonderful research that you've done. We've always felt it's a really critical component of ensuring successful respite, is really helping family caregivers figure out the best way to use their respite time is just as critical as the type of respite they're using for their care recipients. So thank you so much for all this really great information. I don't know if you have any closing remarks you'd like to share or final thoughts.
Yeah, I think I would just like to say thank you to this community, because while we just shared with you kind of a 15 years of research and data that has gone into some of this thinking, this has been a partnership with some of you that are on this line, but many of you throughout all these industries. And that is sort of the most important part of us doing research, that we really are connected to the people that are using services, the people that can benefit from them, from every stage of discovery to implementation of these tools. So thank you to all of you for being our partners.
And thank you all very much for being with us today. Thank you to our presenters. Have a wonderful afternoon, everyone.
Thank you.
Take
Goodbye.
care.